Hello everyone, my name is Chengshuo from the Keio University. I would like to give the presentation of this short paper, Knee Osteoarthritis Classification System Examination on Wearable Daily-Used IMU Layout. Cooperate with the National Institute of Advanced Industrial Science and Technology and Tokyo Medical and Dental University. The knee osteoarthritis as a motion disease has become more and more common in elderly people, especially for the people over the 60 years old. About 10% of males and 18% of females got this disease. The knee OA disease would cause a pain in the knee joint. This is because the cartilage was lost and the knee joint space got narrowed. The disease will limit the motion range of the patient and lead to the inconvenience in their daily life. Therefore, it is necessary to build a daily life screening system for knee OA. It would be helpful to indicate the risk of the knee OA disease. Also, by using a daily life device, the system can be accessed and used easily. Thus, such a system would be a benefit to enable the patient to revert the severity. The knee OA disease is a motion disease that could be reflected by the sample of the motion kinematic data. The IMU is a popular solution that can detect the motion data. So far, the wearable IMU sensor is typically placed on the human body's dedicated parts, such as the upper arm and the wrist. However, since the IMU is cheap and tiny, it can be fused into multiple daily accessories to wear on the human body, and more IMU sensor information from more body limbs can be obtained. It will benefit the building of the complex of human body motions information. Therefore, this paper aimed to establish the knee OA screening system by IMU sensors embedded into the daily objects and found the best IMU sensors combination. It provides a primary proof and possibility to use more daily used IMU sensors worn on the human body to detect the knee OA disease. Here is a related work of diagnosing the knee OA disease. A conventional reliable method is used in the medical image. The MRI and X-ray are the typical diagnostic proof. However, the image-based approach is very expensive, since the patient has to go to the hospital to seek the professional assistance from a doctor. Thus, some other work starts to investigate the non-medical image-based diagnostic methods. For example, the ground reaction force detection to classify the patient and normal people, and the statistic data can be employed as well. The classification system can be trained by the patient demographic and personal characteristics data, such as the BMI value, height and weight, and so on. However, the other method that detect the kinematic data still rely on the laboratory environment and device, which has low accessibility for the end users. The IMU as another popular solution has already been used in motion disease screening, especially for the Parkinson's disease. The related work studying the different sensor placement on the body and features used to build the Parkinson's screening system. But for the knee OA disease, the IMU-based system typically concentrates on the specific joint estimation to classify the patient. Therefore, in this paper, we are going to use the IMU raw data to design the knee OA screening system and figure out its best layout. We have collected total 50 people's data, which included 36 patients and 14 healthy people. The Xsense MTW IMU sensors were used and placed on the 13 body parts from the head to the foot. The participants were requested to walk on a 12 meters length straightaway walkway, and we picked up 15.5 seconds of the data segmentation in length, as the healthy people's data is less than the patient data. To solve the imbalanced problem, as the healthy people's data is less than the patient data, to solve the imbalance problem, we use the data augmentation to balance the dataset. During the training phase, the healthy subject's data was augmented twice. The total pipeline is shown here. Basically, both handcrafted features and deep learning method were used. For the handcrafted features-based classifier, the SVM, decision tree, random forest, and the majority voting classifiers of these classifiers are used. The typically handcrafted features we used in the human active recognition system were extracted from the acceleration and angular velocity signals, and the principal component analysis were used to decrease the feature dimensions into 2. And the acceleration and angular velocity data were converted into grayscale figures and input into a CNN model. The evaluation method was selected as the leaving one subject out cross-validation. To find the best sensor location, the matrix was the AUC value, which is an essential evaluation for the screening system. And to figure out the optimal sensor layout, we used an iterative approach to test the sensor location combinations from 1 to 3 sensors. Here is the result of using one sensor. As the table shows, only one sensor used cannot reach an acceptable result. The AUC values and both sensitivity and specificity was very low despite what kind of the classifier were used. This is mainly due to the low-dimensional input data, which lacks the more effective information to discriminate the patient walking data and healthy people data. Adding more sensors can help to increase the performance. While 2 IMU sensors used, the result getting better. With the SVM used and put the sensors on the right upper arm and left foot, the built screening system can reach the 0.73 of the AUC value. Normally, an AUC higher than 0.7 is an acceptable result. Thus, 2 IMU sensors used are able to reach an acceptable situation. Adding one more sensor is going to make the result better. With 3 IMU sensors used, the majority voting classifier can reach the 0.82 AUC value, which is a very good result. If we see at the layout of the top ranking layout, we can see that the sensor placement are based on the end label basically, such as the lower arm and foot. This is maybe the end limb can normally have more intensive movement and cause more variations of kinematic data, which contains more effective information. This is maybe the end limb can normally have more intensive movement and cause more variation of the kinematic data, which contains more effective information to discriminate the patient and healthy people. In this paper, we merely examined the 1, 2, 3 sensors layout. It is still valuable to see more sensor used layout. However, it needs to consider the user's preference and willing to wear more IMU sensors on the body to reach a balance between the practical usage and the system performance. Furthermore, studying the features of the NEOA screening system is also important to build a high-performance screening system. So far, the number of participants is still at a limited level. It is also important to include more NEOA patients to have an extensive dataset or accumulate longer length motion data at the user end. For example, one-day movement data to make the system more practical. Here is a summary of the project. As the building a daily used NEOA screening system is benefit for the patient, and so we propose to use the IMUs for the whole body to examine the best layout of the IMU sensors. We use the machine learning-based screening system building method and find the optimal sensor placement, and find the optimal sensor placement from the 1 to 3 sensors layout. Thank you very much.